Good evening, everyone, and welcome to the second part of the 6th Jaipur Surgical Tutorial Masterclass on liver space-occupying lesion. These masterclasses are an extension of the academic activities of the online Jaipur Surgical Tutorial, where we conduct a session every Saturday, 9 to 10 a.m. India time. And my colleague, Dr. Anand Nagar, who's an associate professor of HPB surgery at my institution, Mahatma Gandhi Medical College and Hospital in Jaipur, coordinates. So all students and colleagues who want to join Jaipur Surgical Tutorial, please send a WhatsApp message to him at the number given here. Another activity which we have very recently started, mainly for colleagues from Africa, is Jaipur Surgical School because they could not attend the early morning activity. And that is every Friday, 3 to 4 p.m. India time. And that is coordinated by my colleague, Dr. Kailash Kurdia, who's a young consultant at AIIMS, New Delhi. And if you want to join that, please send a WhatsApp message to him. So today is the 6th masterclass of Jaipur Surgical Tutorial. We've earlier conducted masterclasses on living donor liver transplant, safe cholecystectomy, acute pancreatitis, chronic pancreatitis, intensive care of a critically ill patient. And this one is on liver space-occupying lesion. So today's session will be moderated by Dr. Balachandran, who's a HPB and transplant surgeon at AIG in Hyderabad, and by my colleague, Dr. Saraswat. I think he will be joining soon. He's the chief of hepatology at my institution, and we've worked together for more than 3 decades at the SGPGI Lucknow. So I think I will hand over to Bala, because Bala can introduce the first speaker, Dr. Biju, and then maybe I will introduce the next speaker. Bala, over to you.
So we have Dr. Biju Pottakkat. He is professor of GI surgery at JIPMER. He passed out MS from Kottayam and did his MCH from SGPGI, I think 2005. He is a big computer expert, and I thought this topic was ideal for him. Actually, Dr. Kapoor wanted me to talk on it initially, but somehow I couldn't find the time. So I'm very thankful to him to offer this very difficult topic to Dr. Biju. So I think Biju is already on the line. So handing over the mic to Biju. Dr. Biju, you can proceed.
And before Biju starts, I would like to add that after moving out from SGPGI, he has started, established and developed an excellent academic surgical gastroenterology unit at JIPMER Pondicherry, and has an excellent skill lab also there. And he's now moving into the newest field of artificial intelligence and machine learning. Biju.
So when we talk about HCCs are different types of tumors. So our current diagnostic algorithms are basically based upon the imaging. But the character which is used in imaging is the vascularity pattern, the appearance, disappearance, and the density. So essentially, the intense arterial uptake is what is used for diagnosis. Okay. And this vascularity, what is its importance in the tumorigenesis is this vascularity is coming from not from pre-existent vessels. These arterial entities are coming from precursor arteries as well as veins. Okay, so portal vein can also create new vascularity. So with respect to vascularity, when we progress to differentiation, a common misconception is differentiation and aggressiveness are similar phenomenon. It's not exactly similar. Differentiation, when we say mild, moderate, and poorly differentiate, essentially means what is the status of the tumor right now? What is the differentiation right now? aggressiveness is basically the potential to harm. The tumor can be mildly differentiated, but it can be highly aggressive. So this particular phenomenon is very important in with respect to tumor markers. So when we applied our artificial intelligence algorithm to the tumors with a simple HU unit, this is what we get in almost all HCCs. You have mild, moderate, and high aggressive tumors. So basically what happens when the tumor grows, there will be young areas, adult areas, and sleeping areas or old areas. So this is the basis of all this tumor biology and tumor markers. So you can see predominantly aggressive areas in red, moderately aggressive area in another color, and low aggressive area. So in the same size of tumor, same differentiation, you can get this aggressiveness or vascularity, neovascularity. And they are in a different range altogether. And what is the need for biomarkers in HCCs? Okay, so these tumor markers are basically one part of the biomarkers. So they are used for diagnosis, assessing aggressiveness. Again, I'm not talking about differentiation here. It's aggressiveness which I described just now. And for assessing differentiation, it's a separate entity, hence predicting metastasis and prognosis. And also, it has a very important therapeutic and diagnostic application because some of the PET scans are linked with the immunolocalization and the therapy also. So there are different types of tumor markers. So these are secreting substances, tissue-based, cell-based. So all these are tumor markers. Although with respect to HCC, the most famous markers are serum markers. Other markers are also there, which are equally important. It depends upon the tissue what you get. But in the biochemical point of view, they are hormones, enzymes, proteins, and produced by cancer cell as well as host cells. Sometimes what happens? Host cell, there will be some marker which is actually suppressed in the presence of the cancer. So the famous examples are AFP, CA, and CA99. CA99 is mainly in the cholangiocarcinoma, whereas AFP is mainly in the HCC. So one of the important things we have to remember is this: all these cancer, the NIDA starts from the embryological cells. So that's why all these proteins, glycoproteins are basically related to the embryological cancers. Although HCC is not an embryological cancer, it harbors the embryological or differentiated towards embryological cells. So these are the HCC, what we call specific markers. So AFP is the most important one, but the most specific is the DCP or the what we call PIVKA. One important thing what we have to remember in all these markers is all the values are identified ROC curve, and there is no point in asking what exactly is the normal value. There is a point in asking what is the normal range, and what we prefer is either the we get a higher range, very high range, or a very low range. Okay, especially the specificity comes drastically down when it is in the lower range. This factor we have to remember. So nobody should ask what is the exact upper cutoff or exact lower cutoff. It's always a range. But this is very much correlated with the survival. Okay, these markers with a high specificity gives more association with the survival. That's why you can see the PIVKA is giving more association with the survival. High PIVKA values are very dangerous compared to high AFP values. So although it is used for diagnosis, it has a very important therapeutic implication because some of the tissue markers which we are not able to measure in the tissue will be able to measure by indirectly by measuring the serum markers. So even this AFP values, when it is high, it is inducted as a marker in the staging of HCC and also used for transplant criteria, especially when it is more than 1000. There are a lot of criteria or allocation criteria which actually uses AFP along with the tumor size. But when we use that, please understand that most of the values we consider above in the 500 range. We cannot use these values below hundreds definitely, and 100 to 400 is a very precarious situation where you use it for allocation criteria because some patients may not get the organ because of this. It's basically an alpha-fetoprotein is an oncoprotein, and it also increase in pregnancy. So when we can definitely tell, okay, there is cancer is normally in the range of more than 1,000. So the range we can get even in lakhs, 1 lakh, even up to 4 lakhs we have seen. But it also depends on the test, what you do, the measurement, what you do. What exactly the AFP and HCC relation is, it is actually directly linked with the growth and development of the tumor. Okay. So, for example, HCC negative tumors grow slowly. Okay. And also there are not only the growth and development, there are various functions inside the tumor. That's how the patient ultimately dies. There is proliferation, migration, apoptosis, immune escape. All this phenomenon is highly influenced by the presence of AFP. So that's why AFP is really, although it is a very marker with a very low specificity, this is highly linked with the tumorigenesis. So whatever A to Z you want to read about AFP, this is one of our review articles we have written with my PhD student. A to Z regarding AFP is that why it is important still continue as a marker despite all these advances. You can go through and read it. Regarding the DCP or PIVKA2, this is basically prothrombin expressed by in the HCC patients. Okay. The most important you have to remember is if it is showing a high value even in the presence of a negative AFP, this is positive. We have to consider it as a positive for a malignancy. It indicates occurrence of this is a very yesterday there is a patient reported with the same value. You can see the AFP value, it's in the range of below 300. But you can see the PIVKA value, it's actually in the range of lakhs. Okay, this is a middle-aged lady with a so in the tumor there are moderately aggressive areas only. So that is why if it is positive, it PIVKA is a highly sensitive marker. Okay. Now the glypican is another well-researched marker in HCC. One of the advantages of glypican is this is actually can be measured in the serum, but this has very important implications on the therapy. So because of the ease of assessment as well as ease of the linkage of this with the other markers or carriers, this glypican is one of the most important tumor markers researchers are looking for to carry the drug from the bloodstream to the tumor. Okay, so even if you have a high markers, it may not translate into the therapeutic application. So glypican is a tumor marker with a therapeutic application, and there are other less studied markers. But one of the recent advances in the simple C-reactive protein, we know that this we get in most of the inflammation. Now, in the last 5-6 years, the tumor inflammation became very much important. And when we randomly started getting the C-reactive protein in tumors, it shows at least in the upper cutoff or in some patients really in the higher range. So this is also going to have an important marker. It is actually an added in the armamentarium of the tumor markers. So when you go to tissue level, we have several markers, but the only problem is we do not get tissues for biopsy. Even if we get a small sample. So all these markers, it is not possible to get in HCC really well. But if you have a tissue, always try to do it and it will get a good prognosis value. MicroRNAs are the new ones coming in a big way. You need a tissue. You can also measure in serum, but not so specific. One of the advantage of microRNAs, this is compared to other markers, this is related to aggressiveness. Okay, there is more in the peripheral blood. That means you are sitting on the lion is there, very active and roaring. This is what the importance of microRNA. And the last part of tumor markers will be the gene markers. There are mutations. All this is there in other cancers also. That's what it is. So this becomes important only in the presence of tumors because this becomes non-specific markers. In summary, what we see in the HCC biomarker, there are a lot of markers, but finally we are depending on, probably we are going to depend on AFP, DCP, and also microRNAs. Especially when we understand the tumor biology, we will come to know exactly the levels. Now, what we have done in another 2 minutes, I will explain the JIPMER. We had the problem of HCC negative. So we studied some marker called Netrin 4. Okay. So in a large number of patients, 244, including the controls, So Netrin-4, unlike AFP, is present in the normal patient. So this is a suppressor area. So we got very low values of Netrin-4 in HCC patients. So this is an important finding where we try to get this information in the AFP negative patients. So you can see the ROC curve, how it is coming. And this is published in recent publications. And what we see in the AFP negative group, there is so Netrin-4 generally is measured with ELISA. 20 is the cutoff we put from other cancers. And in for AFP, and in less than 20, more than 20 also, you can see that there is no significant difference in the serum Netrin-4 level. So when we compared with the vascular invasion, we took portal vein macro infiltration of the portal vein as the surrogate marker of the vascular infiltration. We found that this Netrin-4 also has some relation, because Netrin-4 basically is an angiogenesis marker fundamentally, and it also relation with the portal vein infiltration. So when you extensively study this entity Netrin, we got more information that as the extent of portal vein or vascular infiltration increases, the Netrin-4 get further and further suppressed, and you are hitting near zero values or less than 10 values. Okay, this is exemplified with this diagram. Now, we also studied all the markers within the tissue level also. The information is really same. Whenever you try to do an angiogenesis marker, it shows high IHC positivity. Okay, all these markers are shown high positive, and these positivities are higher in the vascular infiltration. So, there is a subgroup of HCC which actually have a more vascular infiltration tendency, which may be of similar sizes, may be similar, but these tumors behave little bit differently. They are biologically different, and at the tissue level, this slide shows that at the tissue level also, these aggressives are different. We can, in the laboratory, we can actually find out, and also this information can be used for transplant as well as other therapies. So including VAG for various tumor markers we have studied at the tissue level as well. So you can simply see the difference in the slides where the negative controls and positive controls are coming. And HCC showing a high sensitivity at the tissue level. We also have to remember that negative markers in serum doesn't mean negative markers in the tissue. It can be exactly other way. It can be higher markers in the tissue level, because the expression usually can also happens in the serum. Just 1 minute about intrahepatic cholangiocarcinoma. Intrahepatic cholangiocarcinoma, as you know, that possibly we diagnose as a theory of exclusion. CA19 and CA I already explained. But these are less vascular tumor because the angiogenesis is less, the vascularity is less, and the fibrotic component is more. So these tumors are generally behave like a pancreatic cancers, but we have to remember that it is not not an extension of extrahepatic cholangiocarcinoma. The tumor cells, the origins are different. These tumors are originally coming from the pluripotent liver cells. Okay, this is not from intrahepatic epithelium. Majority of cells as we imagine. It's not intra-bile duct tumors as such. These are the tumors coming from the pluripotent cells. So CA19 is the well-known marker. So again, if it is high, it is specific, but if it is low, despite imaging features, you have to depend on the imaging features. So in general, what we see is AFP for HCC, AFP can be normal at least in 1/3. If it is high, it is sensitive and specific, and PIVKA 2 is more specific. CA19, if it is high, it becomes sensitive and specific for IHC, and it is against HCC also. And thank you very much for the kind attention. Any other questions somebody want to take? I will take. I'll stop here. Thank you very much, sir.
I think it's an excellent presentation, Biju. Must congratulate you on such thorough work and a detailed review of biomarkers, which was very impressive. Particularly the Netrin data are new information for many of us. A couple of things that I think you made a very good point regarding aggressiveness vis-a-vis differentiation right at the beginning and throughout your talk. So, I mean, just for my understanding, I'd like to understand whether with aggressiveness, you relate it to increased vascularity of the tumor, or is it also what we generally talk of as the biological behavior of tumor, same size tumors showing features like vascular, microvascular invasion and distant spread at an earlier stage is what we understand by aggression. Is that correct, or is there it's only a function of the vascularity? The AI graphic hot and cold maps you showed, that seemed to suggest it is vascularity related.
Yes, sir. It is vascularity. So the point which I am trying to make is, at the genetic level, they will have a higher potential to spread. And at the tissue level or cellular level, it may not manifest in the slides. Okay, but it can be manifested in the tumor marker. So in
Right.
every, yes.
So the thing that you say was that the aggressiveness is that by what exactly is the profile or the characteristics which make a particular tumor aggressively invade the vessels and lead to distant spread is what we are looking at. And I think
Yes.
that's not a fully understood phenomenon as yet. But some of these markers, particularly the glypican-3, the glutamine synthetase, HSP70, all these do indicate that. The other set of markers that you mentioned only briefly and in passing was when you talked about the hot tumors.
Yes.
And I think in relation to response to therapy, particularly in response to immunotherapy, it is very important to identify these hot tumors. And as far as I know, short of histology, there is no other way that you can look at the tumors in which there are very high levels of CTL, cytotoxic T lymphocytes, and other cells. And these are the patients which show an outstanding complete response to immunotherapy. About 10% on atezolizumab completely disappear. So this is another set of predictors that of biomarkers which are at the cellular level, which are quite important in therapy. Any other?
Yeah, Biju, two questions. One is on the chat, which says that do we ask a patient, say with a liver as well, to get all these tumor markers which you mentioned, AFP, CA99, CA242, DCP? I mean, how in real life clinical practice, how do we approach it? And second is my question, that how do you use these tumor markers when deciding for resectability, when deciding for PET scan, when deciding for transplant?
Sir, if we first definitely get the AFP, if it is in a very high range, there is no point in getting other tumor markers because we know that they are biologically aggressive. With the moderate range, we always get PIVKA, and if the diagnosis is not clear, we get both. Okay. If PIVKA is very high, again, we know despite AFP, whatever value, it is aggressive. So in doubtful cases, get maximum. AFP should be done in all. AFP is very high. Probably other markers may not have much role unless you are planning a complicated or new therapies. This is what my message regarding say. But we get it all, possibly because of the research purposes also.
And how
regarding the second question, very high levels of AFP, we know that transplant, there is a problem, high recurrence rate after transplant. And this particular part, I request Dr. Bala also to discuss regarding that part.
Yeah. So Bala, what is very high and how do you use it to decide resection, transplant, or not at all resecting?
Yes. As a matter of fact, we actually get AFP and PIVKA for all patients. So as per, there is a lot of literature. Earlier, people used to actually consider for downstaging when alpha-fetoprotein was more than 400. PIVKA never came into that sort of consideration. It was basically AFP because that is more commonly used worldwide. Now, in fact, for better prognosis, people are even looking at doing transplant when AFP is less than 200. That is, when it is more than 200, if possible, and if there is time, it might be better to actually try and downstage it by any modality possible. So we have been actually downstaging if the AFP is more than 400. Below 400, we do take them for transplant. In fact, all centers in India prefer to take the patient for transplant if AFP is less than 400.
So you mean to say that if originally the levels are high, but whatever method you use and bring the level down, that brings down the aggressiveness of the tumor also?
That shows treatment response. And basically, when you are doing any downstaging procedure, after that, you're going to wait for some time. maybe about 2 to 3 months. So in that time, if there is a distant metastasis, you will find AFP value shooting up. So basically, better prognosis is seen if you are able to downstage it to below 400 and keep it at that stage. In fact, we have done about, in our almost 1,000 cases, we have had about 50 patients whom we have downstaged and done. Actually, the results of downstaging and transplant we have found is as good as our remaining subset of patients without HCC actually.
Sorry, I think there is a amount of confusion regarding downstaging. I think this has to do with the Milan criteria, which initially showed us that a particular size of tumor does very well after transplant. And if it is beyond that size, so I think that size is basically a surrogate of biological behavior of the tumor, as is the alpha-fetoprotein and the other biomarkers that Biju has spoken about. And when you are saying downstaging, this comes from the earlier understanding that by decreasing the size of the tumor, getting it within Milan, you will have a great result, which again is a surrogate reflection of the biologic behavior of the tumor. The biologic behavior will not change, but while waiting for downsizing, aggressive behavior tumors will declare themselves and they will go out of the transplant criteria. That selection will happen. So the behavior per se does not change as a response to whatever downstaging loco-regional therapy you have implemented. That is an inherent feature of the tumor. And it only helps us to identify. I hope I'm getting my point across. And those that show a good response to downstaging are those which essentially have good biologic behavior, and a full profile of markers to define what we mean by good biologic behavior is still awaited. A few markers here and there have shown up, and I guess this is work in progress.
Actually, I will put it different way.
Alexa, stop.
Yeah, I will put it in a different way. What we are doing is living donor. And what Dr. Saraswat said is actually applies to disease donor transplant. In living donor transplant, it is preferable if possible. Yes, we have taken patients with alpha-fetoprotein even up to 1,000, 1,500. But when you do that, the recurrence rates are high. So it is desirable that, whenever possible, unless the patient is too sick. LDLT is basically it's a family's own donor. It depends on them. So they need to be counseled. But whenever possible, we do try and downstage when alpha-fetoprotein is more than 400.
No, that's fine. That's policy. But I'm trying to say what we mean by downstaging. Downstaging is not changing biology of the tumor. It is simply selecting those which have a good biological behavior and they do get downstage and do not show up with METs or high alpha-feto during the 3-month wait period. So they will do well. And even in LDLT, I think downstaging now is practiced. It is predominantly concepts have come from DDLT, you're right?
Yes, I totally agree that when we downstage and wait, we are actually giving them a cooling off time. So those who recur in that time obviously drop out. So that's why I said we have roughly about 50 patients whom we have downstaged and done. So we found the results in those patients actually quite excellent. So probably it is just selection with time.
Just a quick response either from Biju or from Bala that if suppose we see a liver SOL, we are thinking of HCC based on imaging finding, but AFP is normal. So what will be your next step as far as tumor markers are concerned?
Sir, we do PIVKA and other markers, but in these patients nowadays, because the advantage of microRNA and other, we always biopsy now. The indication for biopsy are we put the benchmark little bit lower nowadays, and we always do MR imaging, one more imaging, cross-sectional imaging, more tumor markers and biopsy. With respect to one more comment with Dr. Saraswat question, sir. When the tumor is the areas of the tumor which are more aggressive also respond well if the therapy is instituted. The advantage is there is more vascularity there, and some of the resistant areas of tumors are actually the sleeping areas. So it's very difficult when you post-stage, when we did the post-stage imaging with the AI technologies, those physical properties of that black areas remained like that. Whereas the physical properties of the red areas drastically change after TACE or chemotherapy. So this also, the response to therapy is also active biological and active metabolic areas probably may respond more in terms of therapy in HCC. That's yeah, Dr. Bala, please. Yeah.
Yeah,
Let's-
actually,
let's
tumor
move on.
markers are not for are basically to help diagnosis. So a alpha fetoprotein or a PIVKA normal does not mean that there is no HCC. In fact, it would be preferable to go by radiological findings, especially MR angio. I would, Biju had an excellent presentation, but I would also like to add that newer tumor markers like osteopontin, glypican-3, they are actually able to show the possibility of HCC even a year before even the radiological changes appearing. So they may have quite a big role to play in future. But as of now, alpha fetoprotein and
Work in
PIVKA,
progress.
which is basically a marker of tumor aggressiveness, they might be normal. They are not diagnosis. Diagnostic modality is basically the MR followed by CT in my view and in preference.
Okay, I think time for this session is over. So